Hello, and welcome to our online training on effective medical interpretation. My name is Wendy Nakatsukasa Ono, and I'm Program Director for Cardea. On behalf of the California Primary Care Association and Cardea, I'm pleased that you've selected this module to support your professional development. Cardea is a nonprofit, mission-driven organization with a principal team of committed and passionate staff. We've dedicated our careers to helping health and human service providers offer their best to the patients they serve. You may be aware that CPCA is offering this training as part of its Patient-Centered Health Home Recognition Program. This initiative is designed to support member clinics' efforts to move toward and achieve National Committee for Quality Assurance recognition. In this session, we're going to define culturally and linguistically proficient care, describe why professional interpretation is important, and describe how to work effectively with interpreters. Let's start by talking about culturally and linguistically proficient care. At Cardea, we define cultural proficiency as an individual and organization-wide commitment to an ongoing process of working toward equity in multicultural contexts, both internally and in partnership with communities. At the individual level, it includes the capacity to gain cultural knowledge, value cultural strength and diversity, and navigate the dynamics of difference. At the organizational level, it includes leadership commitment to a defined set of values, policies, and practices that enable stakeholders to effectively work cross-culturally. Now that we've defined cultural proficiency, let's talk about aspects of culturally proficient care. In 2006, the Commonwealth Fund produced a report entitled Cultural Competency and Quality of Care, Obtaining the Patient's Perspective. This report identifies 5 aspects of culturally proficient care: patient-provider communication, shared decision-making and respect for patient preferences, experiences leading to trust or distrust, experiences of discrimination, and linguistic proficiency. As you know, patient-provider communication is critical to providing culturally proficient services and can be affected by factors such as differences in verbal and nonverbal communication styles and explanatory models of illness and disease, including use of complementary and alternative medicine practices. Patient-centered care is closely related to patient-provider communication and requires effective partnerships, including shared decision-making among providers, consumers and patients, and families, and respect for consumers' and patients' cultural beliefs, practices, and preferences in weighing available care and treatment options. Patient satisfaction and trust influences patient-provider relationships and is also critical to providing culturally proficient services. Experiences leading to consumer or patient trust or distrust of providers may be related to both individual and systemic issues. Individual issues may include differential experiences with the healthcare system, and systemic issues may include differential access to care. Experiences leading to patient trust or distrust of providers may also be related to both individual and systemic issues. Individuals may include patients' experiences with and perceptions of racial or other forms of discrimination in the healthcare system, while systemic issues may include differential access to and availability of care. Finally, linguistic proficiency, including strategies for communicating with patients who have low health literacy and those who have limited English proficiency, is another aspect that is closely related to patient-provider communication and is critical to providing culturally proficient care. Now that we've had an opportunity to review these aspects of culturally proficient care, let's talk about promising practices for improving capacity to provide culturally proficient services. First, we should take steps to better understand our patient populations. One strategy is to modify intake forms to include questions about health literacy, English proficiency, language spoken at home, and use of complementary and alternative medical practices. Second, we should investigate explanatory models of illness and the impact of those models on consumers' or patients' beliefs, practices, and preferences. Third, we should seek to develop open lines of communication and empower patients to speak up about issues that influence their satisfaction and trust. And finally, we should use bilingual, bicultural staff and professional interpreters rather than family members and friends to ensure quality communication with patients who have limited English proficiency.
So what do we mean by linguistic proficiency within the context of culturally proficient care?
The National Center for Cultural Competence defines linguistic proficiency as the capacity of an organization and its personnel to communicate effectively and convey information in a manner that is easily understood by diverse audiences, including individuals with limited English proficiency, those who have low literacy skills or are not literate, and individuals with disabilities. Often we think about linguistic proficiency as related to individuals with limited English proficiency and individuals who are blind or visually impaired and deaf or hard of hearing, but forget that it also includes those who are not literate or have low literacy skills. Now let's talk specifically about the difference between interpretation and translation. Interpretation and translation are often used interchangeably, but they are different. As defined by the National Health Law Program in its guide, What's in a Word, interpretation is defined as the process of understanding and analyzing a spoken or signed message and re-expressing that message faithfully, accurately, and objectively in another language, taking the cultural and social context into account. The purpose of interpretation is to enable communication between two or more individuals who do not speak each other's language. So, interpretation refers to spoken or signed communication. Again, as defined by the National Health Law Program, translation is the conversion of a written text into a corresponding written text in a different language. So, translation refers to written communication. Now, let's talk further about interpretation. Although legal issues should not be the driving force behind using professional interpreters, and in my opinion are not the most important reasons to use professional interpreters, there are legal obligations that you must consider when you provide services to patients with limited English proficiency. The requirement that recipients of federal financial assistance provide access to individuals with limited English proficiency in assisted programs and activities is not new. With the passage of Title VI of the Civil Rights Act of 1964, the federal government launched a major effort to protect the civil rights and safeguard the health of all people. As an enforcer of civil rights laws and a major purchaser of healthcare services, the federal government continues to play a key role in making healthcare services accessible for individuals with limited English proficiency. Title VI of the Civil Rights Act of 1964 states, "No person in the United States shall, on ground of race, color, or national origin, be excluded from participation in, be denied the benefits of, or be subjected to discrimination under any program or activity receiving federal financial assistance." Therefore, any healthcare provider who receives federal funds is bound by Title VI. In addition, Title VI has been broadly defined to apply to all the operations of federal fund recipients, regardless of the amount of federal funds received. This means that federally and state-sponsored programs such as Medicaid and the State Children's Health Insurance Program, or SCHIP, must comply with Title VI, and that commercial health plans, not just the lines that participate in Medicaid and SCHIP, must comply with Title VI. Since California community clinics and health centers receive federal funding through Medi-Cal, which is jointly funded by federal and state government, and Section 330 grants for community health centers, migrant health centers, health care for the homeless, and public housing primary care program, all programs and activities must comply with Title VI requirements to ensure meaningful access for patients with limited English proficiency. Other entities that must comply with Title VI requirements include primary care clinics, hospitals, nursing homes and home health agencies, and managed care organizations. In addition, public and private contractors, subcontractors, vendors, physicians, and other providers who receive federal financial assistance from HHS must comply with Title VI requirements. Title VI has been consistently interpreted by the courts and the agencies charged with its enforcement to require provision of language assistance services. To provide guidance to federal fund recipients on their obligations under Title VI, the U.S. Department of Health and Human Services, Office for Civil Rights, published a summary of revised guidance to federal financial assistance recipients regarding Title VI and the prohibition against national origin discrimination affecting limited English proficient persons. A link to this guidance is provided on this slide, and there are a number of other helpful resources on the Office for Civil Rights website. Beyond Title VI, there are other federal requirements related to the provision of language assistance services. Section 504 of the Rehabilitation Act of 1973 and Titles II and III of the Americans with Disabilities Act, or ADA, specifically mandate equal access to health care services for patients who are deaf or hard of hearing. Both public and private health care providers are required to provide appropriate auxiliary aids and services to ensure that communication with patients who are deaf or hard of hearing is as effective as communication with other patients. The Hill-Burton Act, passed in 1946, gave hospitals, nursing homes, and other health facilities grants and loans for construction and modernization. In return, they agreed to community service assurance requirements, including providing a reasonable volume of services to persons unable to pay and to make their services available to all persons residing in the facility's area. The program stopped providing funds in 1997, but about 200 healthcare facilities across the country are still obligated to provide free or reduced cost care. The Federal Office of Civil Rights has consistently determined that the Act requires recipients to address the needs of individuals with limited English proficiency. As described earlier, Medicaid regulations require state programs to operate in a manner that is consistent with Title VI. Specifically, states are required to develop a methodology for identifying individuals with limited English proficiency, and both states and managed care organizations are required to provide written information in other languages. In addition, states and managed care entities are required to make oral interpretation available free of charge to enrollees and potential enrollees, and to notify enrollees and potential enrollees that interpretation and translation are available and how to access services. And like Medicaid, Medicare regulations require that all providers meet the applicable requirements of Title VI. Finally, the Emergency Medical Treatment and Active Labor Act, or EMTALA, requires Medicaid and Medicare participating hospitals to stabilize patients during an emergency room stay without regard to the patient's ability to pay. Under EMTALA, signs highlighting the rights of all individuals must be posted in English and any other language or languages that are common to the population the hospital serves. In addition to federal requirements, there are state and other requirements related to the provision of language assistance services. The National Health Law Program has a 2010 podcast on California's language access requirements. A link to the podcast is provided on this slide. The two major healthcare accrediting organizations, the Joint Commission and the National Committee for Quality Assurance, or NCQA, also require linguistic access for individuals with limited English proficiency. And finally, there are professional liability issues that exist for some individuals and organizations. Please note that all of the information and resources provided include general information about legal obligations and should not be considered a substitute for the advice of a lawyer. You should consult with your own lawyer for legal advice. In addition to legal obligations, the U.S. Department of Health and Human Services, Office of Minority Health, published national standards for culturally and linguistically appropriate services in healthcare in 2000. These CLAS standards have since been used by federal bodies such as the Centers for Medicare and Medicaid Services and Health Resources and Services Administration, accreditation and credentialing agencies such as the Joint Commission, NCQA, and the American Medical and American Nurses Associations, and increasingly by health plans such as Aetna, Kaiser, and Harvard Pilgrim Health Care. The 14 CLAS standards are organized by themes: culturally competent care, language access services, and organizational supports for cultural competence. Within this framework, there are 3 types of standards: mandates, guidelines, and recommendations. CLAS mandates are current federal requirements for all recipients of federal funds. CLAS guidelines are activities recommended by the Office of Minority Health for adoption as mandates by federal, state, and national accrediting agencies. And CLAS recommendations are suggested by the Office of Minority Health for voluntary adoption by healthcare organizations. CPCA produced Providing Healthcare to Limited English Proficient Patients, a manual of promising practices. This manual describes community clinics and health centers' obligations under Title VI of the Civil Rights Act of 1964, explains HHS guidance based on the now older guidance from 2000, and keys to compliance. It also describes other important standards and procedures, many of which we've reviewed, and highlights promising practices. A link to this manual is in the resources section. Now that we've had an opportunity to talk about legal obligations, let's look at patient care obligations. Beyond legal issues, professional medical interpretation is important from a patient care perspective. Professional medical interpretation helps us ensure that patients receive care and treatment in a timely manner. It also helps us ensure that we obtain informed consent for care and treatment, make proper diagnosis, and provide proper care and treatment. So let's talk about some frequently asked questions about interpretation services.
Is it okay to use bilingual providers?
Yes, it's appropriate to use bilingual providers if they are fluent in the patient's target language and have that role delineated in their job description. Advantages include that there is no need for interpreters and the provider-patient relationship is preserved. Disadvantages include the potential for error if providers are only semi-fluent and the difficulty of finding providers who speak all patients' target languages. Providers' language skills can be assessed through tools such as the Clinician Cultural and Linguistic Assessment, a tool developed by Kaiser Permanente and administered by Alta Language Services that received an NCQA CLAS Award in 2009. A link to this tool is on this slide. The purpose of the Kaiser Permanente Clinician Cultural and Linguistic Assessment is to determine the level of target language proficiency of physicians who identify themselves as bilingual. Specifically, the CCLA is designed to assess physicians' ability to communicate directly with target language-speaking patients in a primary care medical setting in a linguistically and culturally sensitive manner without the use of an interpreter. It assesses target language proficiency across 5 dimensions: communicative competence, or the ability to meaningfully and accurately understand and produce the target language in a medical setting in a culturally appropriate way; fluency, pronunciation, customer service, and cultural proficiency. The CCLA is administered via telephone and is available 24 hours a day, 7 days a week, with results available within 48 business hours.
Is it okay to use bilingual staff to provide interpretation services?
Yes, it's appropriate to use bilingual staff to provide interpretation services if they are trained in medical interpretation, have that role delineated in their job descriptions, receive pay differentials as appropriate, and can interpret without significant disruptions in other tasks. Advantages include use of existing staff skills and on-site availability. Disadvantages include the potential for error if staff are not properly trained and tested, and the disruption to clinic flow.
Is it okay to use family members, friends, or others to provide interpretation services?
No, except in limited situations. It's important to recognize that even in an emergency or at the patient's request, this can be problematic from a legal standpoint and for quality of care, particularly when using children under the age of 18. In general, untrained interpreters are at risk for adding, deleting, and changing what has been said, and for struggling with basic medical terminology. In addition, family members and friends may have beliefs and interests that get in the way of being able to provide accurate interpretation, and children under the age of 18 may not be mature enough to handle interpreting for their parents or family members, particularly in difficult or sensitive circumstances. Finally, patients may feel uncomfortable disclosing important information that is sensitive in nature around family members and friends.
Is it okay to use volunteer interpreters?
As with using family members, friends, and others, no, except in limited situations, for the same reasons that we highlighted with family members and friends. While volunteer interpreters through nonprofit organizations and churches may be very committed to their communities, the challenge is that these volunteers are donating their time and may not be properly trained or willing to agree to your community clinic or health center standards.
Is it okay to use language lines, whether telephone or video interpretation?
Yes, as long as the language line uses professional medical interpreters. We've highlighted reasons that professional interpretation is important, including legal and patient care obligations. For more information about legal obligations, the Office for Civil Rights has a 4-part video on improving patient-provider communication. A link to the Office for Civil Rights page is provided on this slide, and the link for the video is circled in orange. And, as I mentioned earlier, the National Health Law Program has a 2010 podcast on California's language access requirements. The link to that podcast was provided on an earlier slide. At this time, I'd like to share a 10-minute providing language access video from the Medical Leadership Council. For those of you who are not familiar with MLC, it is a group of leaders from California's medical specialty societies, county medical associations, health plans, and health systems that was convened by the California Endowment in 2002. Today, MLC is convened by the California Academy of Family Physicians and sponsored by the California Endowment. CPCA is a member of MLC. The MLC and its member organizations seek to educate, build capacity, and engage their members on issues of racial and ethnic health disparities and the need for language access and cultural proficiency in California's healthcare settings. In this video, California healthcare leaders talk about many of the issues that we've highlighted up to this point. I hope you enjoyed the video. The MLC has a variety of other resources on its website, including a language access database. A link to MLC's website is provided on this page, and links to selected resources are included in the resources slides. Now that we've defined culturally and linguistically proficient care and described why professional interpretation is important, let's look at how to work effectively with interpreters. Let's start by talking about how to facilitate access to language services. You can facilitate access by informing all patients or their representatives at first contact that you provide interpreters. You can do this by posting a language services sign in your waiting room. Here's an example of an interpreter services sign that was produced by the Massachusetts Department of Public Health. The sign contains the following message in 31 languages. You have a right to a medical interpreter at no cost to you. Please point to your language. A medical interpreter will be called. Please wait. A link to the sign is provided on this slide. The state of Florida has a similar sign in 21 languages. It reads, "Attention, if you do not speak English or if you are deaf, hard of hearing, or sight impaired, you can have interpretive and translation services provided at no charge. Please ask for assistance." A link to this sign is provided on the slide. You can also facilitate access by including a statement about language services in your marketing and patient education materials. Here's a sample statement that you can translate into your patient's target languages. If you do not speak English, or if you are deaf or hard of hearing, an interpreter will be provided for you at no charge. Please let the receptionist know if you need an interpreter. So let's talk about the different types of interpretation. There are two types of interpretation, simultaneous and consecutive. Simultaneous interpretation is when the individual who is providing interpretation services interprets as the patient and care team member are talking. While we define simultaneous interpretation within the context of a healthcare setting, this type of interpretation is used primarily in corporate and government settings. Pros of simultaneous interpretation are that this type of interpretation may be used in healthcare settings when caregivers or family members are listening to dialogue between patients and care team members, as well as in emergency situations. Cons are that this type of interpretation can be difficult and tiring for the interpreter, and the interpreter and provider do not have an opportunity to make sure the patient understands information and instructions that are being given. Consecutive interpretation is when the individual who is providing interpretation services listens to the patient and care team's message and then provides the interpreted message. This type of interpretation is preferred for healthcare settings. When language lines, whether telephone or video, are used, this type of interpretation may be referred to as remote consecutive interpretation. Pros of consecutive interpretation are that this type of interpretation minimizes confusion because the interpreter has time to process and comprehend what both the patient and provider are saying. This is important because there are not English equivalents for some terms, so the interpreter may need to provide a basic, culturally appropriate explanation. And unlike simultaneous interpretation, the interpreter and provider have an opportunity to make sure the patient understands the information and instructions that are being given. Cons are that this type of interpretation may take longer than simultaneous interpretation, so interpreted visits may take slightly longer than non-interpreted visits. On-site interpreters, whether providing consecutive or simultaneous interpretation services, may engage in cultural brokering, essentially serving as a bridge between the patient and provider to help the patient understand the beliefs and practices of Western medicine and its systems, and help the provider understand the patient's beliefs and practices. Now, let's talk about interpretation service models and qualifications of professional medical interpreters. There are 4 primary models of providing interpretation services, and we touched on 2, bilingual providers and bilingual staff, earlier in this module. The first model is bilingual providers who speak the patient's target language. Second, bilingual staff who are trained in medical interpretation and have a range of roles and responsibilities, including providing interpretation services for patients and care team members. Third, staff interpreters who are trained in medical interpretation services and whose sole role and responsibility is to provide interpretation services for patients and care team members. And finally, agency-based or contract interpreters who provide on-site, telephonic, or video interpretation. Agency-based or contract interpreters who provide on-site interpretation are typically recruited, screened, contracted, and dispatched by a language agency. Language agencies provide interpretation and in many cases can also provide translation services for a fee. The California Endowment developed how to choose a language agency, and a link to this guide is provided on this slide. It's also important to note that most community clinics, health centers, and other healthcare delivery systems use a mix of options to meet their language services needs. These options will depend on the makeup of your patient population and the range of resources that you have both within your organization and in the surrounding geographic area. Whether bilingual staff who provide interpretation services, staff interpreters, or agency-based or contract interpreters, qualifications of professional interpreters include being culturally proficient, fluent in English and the target language, excellent knowledge of basic medical terminology, and excellent listening skills and memory. Other qualifications include completion of an interpreter training program, professional experience as an interpreter, and adherence to a code of ethics and standards of practice. The California Healthcare Interpreting Association, a nonprofit organization dedicated to improving the quality and availability of language services in the delivery of healthcare, lists current training programs on its website. These programs include trainings using the Connecting Worlds curriculum developed by the California Endowment and trainings through community colleges, colleges and universities, health plans, and local health jurisdictions. The California Healthcare Interpreting Association also has California Standards for Healthcare Interpreters, ethical principles, protocols, and guidance on roles and intervention in both English and Spanish. A link to the association's website is provided on this slide. In addition, there are other resources available through the National Council on Interpreting in Healthcare. A link to the Council's website is in the Resources section. So now that we've talked about how to facilitate access to language services, types of interpretation and interpretation service models, and qualifications of interpreters, let's talk about how to work effectively with interpreters. As we described earlier, there are three primary modalities of interpretation: on-site, telephone, and video. While many providers, patients, and interpreters prefer on-site interpretation, some community clinics, health centers, and other healthcare delivery systems are using telephone and video interpretation for convenience and, in some cases, cost. Strategies for working effectively with on-site interpreters and those providing video interpretation are slightly different from those for working effectively with interpreters who are providing telephone interpretation. Let's start by talking about general principles for working effectively with on-site interpreters and those providing video interpretation. For front desk staff, it's important to ask patients if they have any preferences before scheduling an interpreter. Depending on the patient and type of examination, she or he may have gender, age, or other types of preferences. When the interpreter arrives, allow the interpreter to meet with the patient before you enter the exam room. Talk briefly with the interpreter before you enter the exam room. When you talk with the interpreter, briefly introduce yourself and establish a relationship, describe the context of and purpose for the patient's visit, and ask about potential cultural considerations. Discuss his or her interpretation style, discuss positioning in the exam room, and determine if she or he has time constraints. Direct your comments and questions to the patient unless you need to ask the interpreter a question. Speak slowly and pause at the end of a sentence or in the middle of a long sentence. Ask one question at a time, avoiding the use of jargon or slang. Be prepared to let the interpreter catch up, particularly when you are discussing more complex medical procedures and/or are using terminology for which there are no non-English equivalents. And finally, talk briefly with the interpreter after the visit, asking for additional input about cultural considerations and feedback about the process. Now, let's talk about a few additional considerations when working with sign language interpreters. Ensure that lighting is sufficient for the interpreter and patient to see each other. Avoid standing in front of windows because the backlight may interfere with the interpreter and patient's ability to see each other. Remember not to pass or stand between the interpreter and patient. And allow time for the patient to review visuals and written information, since deaf and hard of hearing patients cannot both read and participate in interpreted discussion. When working with an interpreter over a speakerphone or with dual head or handsets, many of the principles of on-site interpreting apply. The only additional thing to remember is that the interpreter cannot see visual cues in the room. When the interpreter comes on the line, let the interpreter know who you are, who else is in the room, and what type of appointment this is. For example, "Hello, this is Dr. Salazar. I have Mrs. Wong and her daughter here for Mrs. Wong's annual exam." Give the interpreter the opportunity to quickly introduce him or herself to the patient. And if you point to a chart, a drawing, a body part, or a piece of equipment, verbalize what you're pointing to as you do it. Now that we've talked about interpretation, let's talk briefly about translation. As we discussed earlier, translation is the conversion of a written text into a corresponding written text in a different language. There are two types of translation: written translation and sight translation. Written translation is done in advance, ideally by a professional translator or translation services that will translate, edit, and proofread, and then back-translate key documents such as patient consent forms, patient education information, and clinical instructions. Sight translation is done on the spot, typically by a professional interpreter. It is used to help patients complete forms other than those required for consent or other important purposes, review brief written information, and review English instructions that the care team has already reviewed with the patient. The California Academy of Family Physicians developed the Address Language Access Issues in Your Practice, a toolkit for physicians and their staff members. This toolkit covers many of the issues that we've highlighted in this module, and a link to the toolkit is provided on this slide. Now that we've talked briefly about translation, let's talk about health literacy. Again, we often think about linguistic proficiency as related to individuals with limited English proficiency and individuals who are blind or visually impaired and deaf or hard of hearing, but forget that it also includes those who are not literate or have low literacy skills. As defined in Healthy People 2010, health literacy is the degree to which individuals can obtain, process, and understand the basic health information and services they need to make appropriate health decisions. As outlined in the Commonwealth Fund's report entitled Health Literacy Practices in Primary Care Settings, Examples from the Field, promising health literacy practices include viewing health literacy as a team effort, beginning with the front desk, using standardized communication methods and tools such as motivational interviewing, as well as other tools such as the American Medical Association's 6 Steps and the National Patient Safety Foundation's Ask Me 3. Promising health literacy practices also include using plain language, sitting face-to-face with patients, using simple diagrams and pictures to illustrate explanations, and using educational materials that have been designed for individuals with low health literacy, usually at a 6th grade reading level, as well as committing at an organizational level to creating an environment in which health literacy is not assumed. Earlier, I mentioned the American Medical Association's 6 Steps and the National Patient Safety Foundation's Ask Me 3. Let's look briefly at these tools. In its Health Literacy Educational Toolkit, the American Medical Association highlights 6 steps to improving interpersonal communication with these patients. First, slow down to help foster a patient-centered approach to the clinician-patient interaction. Contrary to popular belief, research shows that patient-centered visits do not take substantially longer than traditional visits and create an atmosphere in which patients feel their needs are met. Second, use plain, non-medical language. Use high blood pressure versus hypertension. Keep track of or keep an eye on versus monitor. And poisonous versus toxic. Third, show or draw pictures to improve patients' understanding of information and instructions. Fourth, limit the amount of information provided and repeat it to enhance the patient's recall. Focus on the 1 or 2 main things that the patient needs to know during this visit. Fifth, use the teach-back technique. Confirm that patients understand by asking them to repeat the information or your instructions. And finally, create a shame-free environment by encouraging questions and using tools such as Ask Me 3. Ask Me 3 is a patient education program designed to promote communication between healthcare providers and patients in order to improve health outcomes. It encourages patients to ask and providers to answer 3 basic questions during each encounter. What is my main problem? What do I need to do about this problem? And why is it important for me to do this? At this time, I'd like to share a 4-minute video on Ask Me 3 from the National Patient Safety Foundation.
As a patient, you should expect safe care, and you should also take steps to help ensure you receive safe care. Clear communication between you and providers and being an active member of your healthcare team is important for keeping you healthy and safe. Asking your doctors, nurses, and pharmacists and other healthcare providers questions so you understand your main problem, your plan of care, and what you need to do for your main problem is an important first step. Now, more than ever, patient and family engagement is needed to help you receive the best healthcare possible. You are an important part of the healthcare team. Be an active member of your healthcare team. Ask questions early and ask questions often. The National Patient Safety Foundation encourages you, the patient, to be an active member of your healthcare team by asking 3 simple but important questions every time you talk with a healthcare provider. The 3 questions are: what is my main problem? What do I need to do? Why is it important for me to do this? Ask Me 3. Good questions for your good health.
Joe, I think your shortness of breath and swelling are caused by congestive heart failure. We need to schedule an echocardiogram to find out what the cause is. The echocardiogram will determine your ejection fraction and if there are any underlying issues with your heart valves. In the meantime, I'm going to start you on a couple of medications, Lotensin for your high blood pressure and Lasix for the swelling.
Okay,
Do either of you have any questions?
so I have high blood pressure. Is that my main medical problem?
No, high blood pressure is not your main problem. Your main problem is congestive heart failure. This condition causes your heart to be weaker and have to work harder to pump blood through your body. It can cause swelling in your legs, and it can cause shortness of breath.
Okay, I think my brother may have the same condition. What do I need to do?
First, before you leave, let's schedule an appointment for your test. After you leave, you need to get your 2 prescriptions filled. And finally, you need to take your Lotensin and Lasix. I suggest that your daughter and you write up a schedule for your medication.
A written schedule of my father's medications will help. Why is it so important for him to have the test and take these medications?
Those are really good questions. The echocardiogram will hopefully tell us exactly what's causing the heart failure. The test will also help us find out how far along the heart failure is. It's important to take your medications because you're helping your heart not work as hard. The swelling will decrease or disappear, and you're slowing down the disease. Does that help you understand why the test and medications are important?
Yes.
Yes, I understand. I'll make sure to schedule my tests and take my medications.
In this scenario, Joe asked 3 simple but important questions. By asking questions, Joe was able to be more informed about his main problem and everything he needed to do. Also, his family member was seen writing down the information. When you visit your doctor, if you're in the hospital or at the pharmacy, always ask and write down the answers to these questions. What is my main problem? What do I need to do? Why is it important for me to do this? For more information about Ask Me 3 and communicating well with your healthcare providers, visit www.npsf.org.
I hope you enjoyed the video. The National Patient Safety Foundation has a variety of other resources on its website, including a resource center, an online learning center with links to courses that offer CME and CE. A link to the National Patient Safety Foundation's website is included in the resources slides. Here are resources on cultural proficiency. And here are resources on language access. This concludes our online training session on effective medical interpretation. Again, this webinar is part of a series of online courses provided by the California Primary Care Association as a demonstration of its mission of strengthening its member clinics and networks through advocacy, education, and services in order to improve the health status of their communities. For information on other online training opportunities, please visit the websites for California Primary Care Association and Cardea. Thank you for your participation.